Hello, everybody. So it's a great pleasure to speak at the AOCCN in this epilepsy session. So let me share my slide. So the topic that I'm going to talk is about the source dipole modeling, exhibit 2, our research topic. Then in patients with the drug-resistant epilepsy who candidate for the surgery, the non-invasive functional imaging method helpful in guiding placement of the surgical resection or invasive EEG recording. So EEG source imaging or ESI is a non-invasive recording of electrical potential field on the skull while using dense array EEG that can be up to 256 channels, which allow estimating of the intercerebral electrical source. So nowadays, ESI became more accessible techniques, so mainly due to the increase in computational power and appearance of the user-friendly sophisticated analysis software. So we're looking about utility of the ESI or EEG source imaging in epilepsy. It can be used accurate definition of the focal epilepsy, can use identification of the elicitative zone, identification of the ictal onset zone, and can be used like the physical assessment patient with refractory focal epilepsy that I go to discuss later. And identification of the seizure network, like the looking about the seizure propagation, and identification of the eloquent cortex, for example, like the identify of the visual, auditory, or somatosensory region. So let's come to look about the principle of the ESI. In theory, determining exact location of electrical source in brain from only skull recording EEG data called inverse problem is impossible. However, if characteristic of the volume and location of the source known skull voltage field can be used accurately predict, we call the forward problem. So solving forward and inward problem not straightforward and require two independent mathematical algorithms by using the volume conductor model for forward problem and the source model for the inward problem to identify the EEG source imaging. So when we talk about the forward problem. The forward problem of the EEG refer to the difficulty in predicting surface field potential. This problem can be solved by specifying sets of known conditions for the head model, and then calculating about potential at the recording electrode. And solving the forward problem or estimate field distribution on the skull is extremely difficult, owing to about inhomogeneous of the brain structure. For example, like the brain have a south side and a J-line. And another problem is about anisotropic property of the brain, because the brain can have a different density of the tissue, like the fluid, meninges, skull, and skull. So to do that, we have to get the head model. We have a two broad category for the head and volume conductor model are used for the ESI. So one, we use a spherical shell model, and another one more sophisticated we call realistic head model. The spherical shell model with assumption that the conductor property throughout the head is uniform. That's the simplified head model. Theoretically, more sophisticated realistic head model are used more recently. That's based on high resolution MRI scan of individual patient, offer better solution than the spherical shell model. So most popular technique for realistic head model are boundary elementary element methods, we call the BEM, or finite element method, or FEM, or finite different method, or FDM. This is a model of realistic head model. So we have used two methods. One is the forward problem, and the one is inward problem. The forward problem is to determine the field from the known source, and conductor in the call for the forward problem. And also we use the inward problem to determine the source or imaging from the known field, and conductor is called the inward problem. So the inward problem, the problem of identifying the source of the given surface field is a contradistinction to the forward problem. Potentially infinite number of the source within the brain can produce similar scale recording field potential. That's why a priori assumption of source and volume conductor are required to solve inward problem, because when we got the EEG, we difficult to know the number of the source within the brain, we still unknown it. And then we need to use a volume conductor to require to solve the inward problem. That's after we got the EEG source imaging by the dipole model or dispute model. That we're going to talk later. The single dipole model, most commonly used as the source model in clinical setting in single equivalent current dipole. Under this assumption, dipole model never reflect biological fact that we already approximately about the reality limited number of conditions, such as the epileptic spike or early component of the auditory evoked potential. The map compared with the measure potential map to identify base location of the source as displayed on the video on the right hand side. Each subsequent field measurement can also be modeled by another single dipole using the same method, which result in the data from serial of dipole with different location and orientation called the moving dipole model. This sequential model single dipole adds sum to approximately about the source of the propagation. So dipole model can be used in different model, like the moving dipole model, rotating dipole model, or maybe the fixed dipole model. That the different time, because we voltage potential maybe change within the time. So compare with the multiple dipole model and distribute source model. The multiple dipole model adding complexity to the source localization. A given scale recording voltage field can represent activity from more than one source. In this case, a more advanced dipole model, such as the spatial temporal multiple source model, can be applied. This technique involves the fixation of the location and orientation of the numerous dipole over the given time interval with the entire block of data. For the distributed source model, another common use approach to solve the inward problem does not require priori assumption on the number of dipole. So based on the assumption that the multiple source can be symmetrically active across many locations at any given time. So distributed model reconstruct cerebral activity at each point on the 3D grid. This show up the model of the dipole in spherical head model and the dipole in realistic head model. So show up the realistic geographic provide the factor improvement, particularly important when the consider source place in the temporal or in the occipital cortex. So this picture, your video show up that the realistic head model show very fit dipole when the focal epileptiform discharge come from the mesial temporal lobe better than the spherical head model. Practically and pitfall or ESI, several important steps to process of the obtaining accuracy of the ESI result. Error of the 1 to 2 centimeter can be displaced source of the localization from area, for example, like the orbital frontal lobe to the temporal lobe, or even from the occipital lobe to the parietal lobe, or from the right mesial frontal region to the left side. Such an error margin is unacceptable when epilepsy surgery is considered in this area. So choosing appropriate forward and inward solution, meticulous attention to technical recording detail is very crucial for planning epilepsy surgery. How about the number of location of electrode? The higher the number of electrodes result in smaller dipole localization error. The maximum of 2 to 3 centimeters of inter-electrode distance required to avoid distortion of potential distribution of the skull. Relationship between the number of electrodes and position of the source localization is nonlinear. Achieve plateau at allow wider electrode for distribute inward model. However, more recently, study using the restrictive head model finish different model and realistic value of brain and skull conductive characteristics show the improvement of the term of localization can be attained when we use electrode up to 256 skull electrode. So electrode and the MI correlation is another basic very technique to use at this to identify the ESI. At the source location, calculate relative to electrode position, co-register of the electrical source with analytical space in important step in the ESI. Because the head shape and size vary among the individual patient, so knowing where recording electrode located in individual head is very important. Incorrect assumption electrode position can lead to inaccurate ESI result. Several methods of the electrode localization have been used, such as the electromagnetic digitization, ultrasound digitization, MRI localization of electrode, and the geodesic photogram matrix system have been introduced. The electromagnetic digitization commonly used. So this is how show up the flow diagram of the ESI processes. The source imaging with the realistic case model require the three inputs. One, the EEG recording. Second, the patient MRI scan. And digitized coordination of EEG electrode, very important. And then also the MRI scan processing by the segmentation put in the realistic case model, and then use a forward solution calculation. And then after that, after the EEG analysis, pre-processing, remove the artifact, and then by the analysis with the mathematics and fitting and the analysis of the source localization, that we can get the ESI matching very nicely on the MRI scan. So ESI of the intellectual spike, intellectual form activity is complex phenomenon, and propagation of activity from source to remote cortical region can occur within milliseconds. So information from provided by EEG spike source localization, even if technically accurate, may not reflect about the actual source of the observed spike. Elicitative zone where the intellectual spike generated could be distant or completely separate from the seizure onset zone and the epileptogenic zone. So the best and probable the only to assess the accuracy of the ESI in localization of the epileptic spike compare result of the EEG source modeling to that of the simultaneous spike recording from the intracranial EEG. So to date, several studies attempting to determine accuracy of ESI for source localization of interictal spike. Overall, the study consistent show ESI have a high positive predictive value. How about the sensitivity and specificity of the ESI compared with the PET, interictal spec, and MRI scan? The ESI no significant difference in sensitivity and specificity between temporal and extratemporal epilepsy. ESI add any information to visual EEG analysis that ultimately influence the surgical decision making remain to be investigated. At present, ESI seem to be promising technique, positive contribute to visual EEG analysis in localization of epileptic spike. They serve as a role in epilepsy surgery evaluation. Intracranial analysis and the ESI. In select cases, recording acquired from implant, subdural, and the dead electrode intracranial during pre-surgical evaluation. Model and imaging source dynamic of electrocorticographic from the ECOG or maybe from intracranial EEG data before and during and after occurrence of epileptic seizure in 15 minutes of data of a patient with an implant, electrocorticography electrode, grid or strip. Accuracy of the source localization heavily influenced by electrical head model have been used. So simultaneous intracranial and skull recording show analysis of the skull spike provide more reliable localizing information about epileptogenic zone than analysis of the ictal activity, principally due to less extensive propagation of interictal compared with the ictal discharge. However, even though we're looking about the single spike, the substantial propagation may already occur, leading to the incorrect result like in this picture. You see that when we analyze it with different a few millisecond duration, ESI of the initial phase of the epileptic spike show could be misleading to another location, like the Dipole show different location on the MI scan. So only certain segment of spike, in particular during the rising phase, provide the good localization information. So also ESI can use for identify eloquent cortex. That really can be useful for the pre-surgical evaluation. Clinical focus, mainly identification of the eloquent cortex. For example, like the primary somatosensory, visual, and auditory cortex, and auditory evoked potential. Accuracy localizing of primary somatosensory cortex has been subject value in pre-surgical workup and surgery in patients with refractory epilepsy when epileptogenic zone close to this cortex. Localization can aid surgical planning for resection or placement of the intracranial EEG. Capacity of the source imaging program to accurate source image evoked potential component engender greater faith in the program accuracy in source imaging of epileptic spike or seizure. This video presents one case. We have a refractory focal epilepsy. We use CSI to identify eloquent cortex that's about the occipital cortex area. So the ESI still underutilized in many epilepsy surgery centers. This I show up the current data from use of ESI imaging and also electromagnetic source localization in epilepsy surgery center across Europe. So we found that the less common use of the ESI EEG source imaging only 38% only. The low usage of the ESI when compared with other imaging like MI scan, PET scan can be used about 92%, SPECT 79%. It's due to the needs of the required technical expertise together with the special software. So ESI is usually not applied on typical long-term EEG recording, but on additional EEG recording for source localization, which might be increase the cost. Also, no recommend guideline in the pre-surgical evaluation yet, so that the future might be we can have some guideline to use ESI for pre-surgical evaluation. Accuracy of the ESI from electrical discharge for pre-surgical investigation. The overall accuracy of electric source imaging in the lab cohorts of patients undergoing pre-surgical investigation for drug-resistant focal epilepsy. A highest sensitivity and specificity can be found about more than 80% of ESI with relief from the high resolution EEG and individual head modeling using volume of resection combined with the post-surgical outcome. X10 study of the result show allow one study about 58 patients with present of the concurrent structural MI scan with the ESI have a strongest predictor of the post-operative seizure freedom. There is a study, a prospective study show ESI of spike clearly contribute to estimate epileptic zone and can play an important role in non-invasive pre-surgical evaluation by comparing to the invasive stool EEG. So patients where ESI have a high accuracy and would be clinically relevant in particular group like the frontal lobe epilepsy. This study showed that the frontal lobe is have a high concordant data with ESI, negative MI scan, and also present of the malformation cortical development. Compare reason with other non-invasive technique. In addition to long-term monitoring EEG recording, physical workup includes the high resolution MI scan, PET, and SPECT. Nevertheless, when this method unable to precisely localize epileptic focus, invasive recording from surgical implant electrode might be required. So accurate localization of seizure zone with priori hypothesis allow better preparation for placement of intracranial electrode implantation properly and to avoid something like the fishing allow over the cortical area without any limited hypothesis for the epileptic zone. So ESI is a non-invasive technique, provide the superior temporal resolution in milliseconds compared to other methods based on change in the metabolic and vascular correlate with the neural activity. So ESI can be performed at the patient bedside and suitable in pediatric population, and also even though in the cognitive impaired patient. So this is a study comparison with the ESI with other non-invasive technique. It's a prospective study. ESI with compared with MRI scan, PET spec in 152 patients, operate epileptic patients with a follow-up period of more than 1 year. ESI using individual MRI scan showing the high sensitivity with 82% and specificity about 68%. MRI scan, the sensitivity only 76% and the specificity about 50%. PET scan about 70% and 40%. And SPECT scan is a sensitivity about 60% and specificity about 48%. ESI from intellectual discharge in pre-surgical evaluation is a study, one study of the 43 temporal lobe epilepsy patient recording with the high den EEG, 256 channel EEG, confirmed the result showing our sensitivity about 91% and specificity about 75% of the sublobar level. Using the high density EEG recording study demonstrate about the correct localization on the lobar level up to 93% of the 32 patients. ESI, also the recent study, is about to properly located epileptic zone in 12 among the 14 patients with very large brain lesion. So this example of the source localization with linear distribute inverse solution compared in the template MRI scan and individual MRI scan can be delineate about the localization of the epileptic focus in the patient who have a large lesion. ESI in patient with no apparent brain lesion being capable of approximately localization epileptic focus in around 8 in 10 cases. ESI also would provide relevant information concerning about the epileptic focus, particular difficult group of patients in which MRI scan provide no significant information. In another study of the ESI from intellectual discharge, in 38 patients with the intracranial EEG show the median distance between interictal zone and electrode identified as belonging to seizure onset zone was only 0 millimeter with interquartile length about 0 to 14 millimeter. Also, the localization of the spike with the high density ESI correctly identified the seizure onset zone in most of the patients. And the median distance between ESI maximum based on spike and seizure onset zone was only 17 millimeter. How about the ESI of the ictal onset? One advantage of EEG over the MEG is we can perform very prolonged EEG and can be routinely performed in record seizure and identify seizure onset focus. However, analysis of ictal data using the source modeling technique is complex, time consuming, and labor intensive. In some studies, successive source modeling was reported only about 30 to 40% of the patients. Ictal source modeling is difficult for several reasons. One is a certain type of seizure generates substantial muscle and movement artifact when the seizure started, will result in the low signal-noise ratio. So secondly, ictal rhythm can only be recording at skull, where there is a sufficient synchronization of cerebral activity by that point. The cortex adjacent to or distant from the seizure onset is already involved. So particularly when the seizure is spreading very quickly. Also, some seizure might show detectable skull EEG change very related in the seizure, as observed in the compared with the intracranial EEG study. And also ictal ESI therefore identify not only ictal onset zone, but also the cortex to be the seizure already spreading during an early ictal event. So early study with single and multiple dipole will fit in time or frequency domain show a high correlation between dominant source component and location of the seizure onset. So ictal activity involving spatial temporally over time dynamic analysis of the ictal discharge in given time window should be performed to accurately determine origin and propagation of the ictal activity. Seizure progress from second to minute. Localization of source would require substantial number of inward problems to be solved. Dynamic spatial temporal approaches decomposing seizure into several components and then localizing and recombining the source of each of these components effectively decrease the complexity of the ictal source analysis. So analysis of the ictal ESI have been limited to continuously rhythmic activity. The problem with the localizing seizure onset with the ESI is that the fast propagation of seizure activity can lead to the long identification of the seizure onset zone. Study applied by user phase corrected frequency source analysis to determine which areas start first with the most prominent initial ictal frequency. The source reconstruction of predominant frequency concordant with the intracranial finding show up in 7 cases. Frequency profile dipole resolve prominent frequency during different periods allow seizure onset in different patients. So this is one example of this guy, 32 years old, who have a refractory frontal lobe epilepsy and with MI negative, have a PET ictospec ESI, and use ESI of the ictal onset, show the location of the placement about the intracranial depth electrode, and then patient have a surgery later on, and pathological show the cortical dysplasia. Also, the study used independent component analysis in the time frequency domain to determine map that represent about rhythmic discharge of the seizure onset. Localization of the source of this map closely correspond to the seizure onset zone determined with intracranial recording. So after they do the ESI, ESI located on the area that they put on the grid covering of this area and resecting cover this area and make the patient have a seizure-free 1 year follow-up after the surgery. So in my conclusion, ESI is a non-invasive promising tool to help the localized epileptic focus. Tremendous progress have been measured in technique of ESI in recent years, easily applied in clinical setting, not require highly experienced personnel. And also with using of the realistic head model, e.g. along with the ESI co-registration on the patient MI scan instead of the template MI scan improve about the accuracy of the ESI. Commercially available EEG recording allows short and comfortable session and even long-term monitoring acquisition possible. And more advancing ESI method show promise and development of the user-friendly program open path for the extensive clinical study in the lab cohort to demonstrate the value of ESI in physical evaluation of patients with epilepsy, precise localization of eloquent cortex, and ESI ictal discharge in physical investigation. Although at present, it cannot be used to replace the intracranial EEG, but ESI may be useful to guide at the placement of intracranial electrode. That's the end of my talk. Thank you very much for your attention. Thank you very much. Bye-bye.